Thank you very much, Libby, and welcome to everybody. Let me share my screen. I think you should be able to see in presentation mode. So just a correction from Libby's intro, I'm actually from the University of Washington, not Washington State University. There's a little bit of distinction there. And again, welcome to everybody. Today we'll be talking about best practices in engaging Latinx in care during COVID. Just my disclosures, I've got no conflicts of interest or any relationships to disclose. And just like Libby mentioned, I come from the Mountain West AIDS Education and Training Center. I am the Washington State Training Coordinator. The AETC, the Mountain West AETC is part of a regional collaborative of training centers throughout the country that were funded by HRSA, the Ryan White Program, Part F. If you are joining us from different parts of the country, you can get more information about your local AETC by visiting the AETC.org website, and you'll be able to link up to your state AETC partner or the regional partner based in one central location in your area. In the Mountain West region, it's the University of Washington is the main hub. Now, the objectives, we're just going to review the current state of the HIV epidemic and COVID among Latinx and discuss some successful strategies and practices to engage and retain Latinx patients in care during COVID, and then review the benefits of utilizing telehealth for patient and provider engagement. I'm going to be going through some of these slides rather quick because I've got a lot of content. Not a lot of time, so I might skip on some of these. I might skip some of these slides, but I mean you'll have access to the slide set through the conference. And just right now, I'd just like to pause just for a couple of seconds, just to recognize, what happened last week in Atlanta, and just recognize that as a person of color and as a people of color. The Asian Pacific Islander community, the Latinx community in this country. I mean, we all come to the United States in search of a better life for our families. And, my personal life, my partner is of Asian descent. Kids are Latino and have Asian. So, the tragedy that happened last week really had a big impact on us. And it just brought back feelings of trauma about, the El Paso shooting a couple of years ago in Walmart. So I just want to take a couple of seconds just to recognize the victims and just for us to pause about, what unites the Latino community and the Asian Pacific Islander community in the United States. Okay, so before we get started, as you probably saw in the title slide, I used the term Latinx. There's still a lot of discussion going about the use of the term Latinx, whether it's a term that the Latino community prefers to use, whether it's something that's imposed. I'm going to be using these terms interchangeably: Latinx, Latino, Latina. Even some of my slides that I obtained from other sources still use the term Hispanic. So I'm going to be using them interchangeably throughout the presentation. I do recognize that the term Latinx is being used with more frequency, and there is a great reasoning why it's being used. I also recognize that some people might not feel comfortable with the term yet. So as a way to recognize these differences and opinions that we might have, I'm going to be using these terms interchangeably. And that's not to take or to give, more or less importance to any term. I just want to recognize that as we move forward. Just think about, when was the first time that you heard the term? Was it in the past year? Was it in the past 3 years or 3 to 5 years? And that's the term Latinx has really it's becoming more and more common to use, or at least we're hearing it with more frequency compared to what we used to hear it, 3-5 years ago. So again, just think about it, and the context also of when you heard it. So first, I'm just going to go quickly through reviewing what is the current state of HIV among the Latinx community in the United States. Obviously, right now, with the new HIV diagnosis in 2018, the population group that's most greatly affected is the Black and African American community here in the United States, followed by the Hispanic, Latino, or Latinx community here. And when we really start breaking down those numbers, we start seeing that, MSM, men who have sex with men, are still the most at-risk group, whether it's in the Black African American community, Latinx community, the white community. I mean, MSMs continue to have the highest rate of new HIV diagnosis in the United States. Then when we start looking specifically among the Hispanic Latino community in the US, as we mentioned, MSM, 85% of new diagnoses still occur among MSM, Latinx MSM, among men, followed by heterosexual contact, whereas with women, 87% occur because of heterosexual contact, followed by injection drug use. So what this means is that 28 new HIV cases are detected every day among Latinos in the United States. And 9 out of those 10, it's Latino men who account for those cases. And out of those 9, 8 were among Latino MSM. So it just puts into context, the numbers that we're seeing, on a daily basis here in the United States. Now, among the highest risk groups, we still, 1 out of 4 Latina trans women is estimated to be living with HIV, 25%. To put that in context, 1 out of 4. And those are truly, truly shocking numbers. Now, if the current HIV rates persist, we're talking about like 1 in 5 Latino MSM may be diagnosed with HIV in their lifetime. 1 in 48 Latino men, 2%, and 1 in 227 Latino women may be diagnosed with HIV in their lifetime. If we did nothing, we just continue doing what we are doing now. So the challenge is always how to improve these numbers. Of course, you cannot. Okay, so got a question in the chat. If I can clarify what MSM? MSM means men who have sex with men. Hombres que tienen sexo con hombres. So 53% of Latinos have never been tested for HIV in their lifetime. No, like the first time I ever got tested for HIV in my lifetime was when I had to, as part of my immigration process. So it wasn't even because I went to a health center for something, that it was part of a routine care or a routine checkup. It was because I had to do it. So 53% of Latinos in this country have never been tested for HIV. So if you don't test, you cannot find out, if a person is HIV positive or not. So the care continuum, and this is what, when we start looking at the numbers as a whole, between 2015 and 2018, we will see that it's pretty much stagnant. There really hasn't been any, significant improvement in any of these numbers. They more or less remain the same percentage-wise. Latinos who have been diagnosed with HIV, and out of those, those receiving care, those retaining care, and those who are virally suppressed. And there's a lot of research out there that has been done in the past 5-10 years, that the sooner you get individuals virally suppressed, the less risk they have in transmitting the virus to other people. So there's been a lot of advancements in antiretroviral medications over the last 10, 20 years. It's no longer, having to take 20 pills. Now you just have to take maybe 1 or 2 pills. So it's easier. The challenge is, with everything that goes around HIV, the stigma, the, access to care, how to be able to detect individuals who are at risk, get them tested, detected, find out that they're HIV positive, get them into care, retain them in care, and then getting them virally suppressed. So what this chart basically shows us is that there's still a lot of work to do. Pretty much everything has remained rather stagnant in that time frame, 2015 to 2018. Now, estimated new HIV infections and PrEP use. For those of you who are not familiar to what PrEP is, pre-exposure prophylaxis, this is a drug that you take once a day, a little blue pill. You take it once a day, and over time, it's 99% effective. That's if you continue to take it every day, even if you're at risk for HIV, 99% effective that you won't contract HIV. Now, if we see the breakdown between population groups, what this chart, what these two pie charts show us is that while Latinos make up 27% of estimated new HIV infections, we only make up 13% people who are actually using PrEP. Same thing with the African American community. The African American community, 42% of new HIV infections, but only 10% of PrEP use. Whereas with the white community, it's the other way around. So what this shows us is that among people of color, there's still a lot of work to do with HIV prevention and getting people to use, to access PrEP. Now, again, still looking at the trends by race and ethnicity, we can see that from the time frame from 2014 to 2018, there has been some improvement in some of these communities. Small improvements, but at least improvements. Among American Indian and Native and Alaskan Natives, 6% increase in HIV diagnosis. Now, maybe some of this is because of better testing, but maybe increased access to healthcare. But the fact remains that these numbers have gone up 6%. For the Asian Pacific Asian community, it's more or less remained stable, with the Black African American community a 7% decrease, Hispanic Latino, Latinx community stable, Native Hawaiian and other Pacific Islanders has gone up also 55%. That's a huge increase. But again, it might be because of increased access to healthcare. We don't know. Among the white community, 8% decrease, and among multiple races, a 42% decrease. Now, when we start breaking down the trends by age and by sex or by gender, specifically among Hispanics and Latinos, we see that there has been a 10% increase among that age range of 25 to 34 years old. So there's a lot of work to do among this, this young adult population, and also among the 55 and older population as well. There has been a 12% increase. Now, by sex, among men, it has remained stable, although we just saw, we're almost at 7,000, 8,000 cases per year. Among women, it has decreased. But as the age chart shows us, is that age range 25 to 34 and 55 and older. It's really two age ranges that we really have to pay close attention to and focus and redouble really our efforts on. Now, what are the hotspots of HIV diagnosis around the country? So 7 states plus Puerto Rico account for roughly 8 in 10 new HIV diagnoses. Of course, these happen to be also some of the states with the highest concentration of Latino residents around the country. So in a way, that's not surprising. But then now in 2016, 65% of all Latinx people living with HIV resided in the 57 jurisdictions that are targeted by ending the HIV epidemic. And this was an initiative that was initiated under the previous administration, where a lot of resources were put into specific counties and states that had high rates of HIV. So, and here you can see the counties and those states that are part of the ending the HIV epidemic. Now, among Latinos, among Latinx in 2018, what this map shows you, and this is courtesy of HView, which they have incredible maps and graphs that you can download. It shows you where the highest rates of HIV for Latinx are around the country. So no surprise, the Miami-Dade County area down in Florida, Houston, Southern California, New York State, the area around New York City, New Jersey, that area, Washington, D.C., parts of Virginia. And at least for me, closer to home, in the Mountain West region, the 10 states that make up the Mountain West AETC region, the highest geographic areas with incidents are, King County here in Seattle, and then, Colorado, Denver, Colorado, those two big major metropolitan areas. Now, I'm going to shift and start talking about COVID-19, because obviously COVID-19 has had a huge impact in the Latinx community and its access to healthcare over the past year. I think everybody has been impacted by it some way or another. And this chart, it's heavy, I know, but the two things I want to highlight, Latinx, we account for 18.5% of the US population, but for 29.5% of COVID cases. So, and this is just where race is known, because as we know, some states, some jurisdictions, some counties do not even collect race data. So these numbers might be even worse if this data had been uniformly collected. And the other thing, Latinos are hospitalized from COVID at 4.6 times the rate of, white people. So moving on. In a couple of weeks ago, the conference on retroviruses and opportunistic infections, CROI, took place. And there was this abstract from Jessica Islam from the University of North Carolina at Chapel Hill that really explored the racial differences in COVID-19 infection rates among people living with HIV in the United States. And some of the things that I wanted to highlight here is that what they found was that, obviously, no surprise, racial minorities are disproportionately affected by COVID-19 and HIV. And as we talked about in the earlier slides, among HIV, it's MSMs that had the highest numbers of new HIV infections or diagnoses, 2018. Among COVID-19 and COVID-19, the highest mortality rates or deaths are among Blacks, followed by American Indian, Alaska Natives, and Hispanic Latinos. And what they used to get this data was they used EMR data, medical records data, and that's how they were able to examine the racial and negative disparities in COVID-19. Now, what's interesting is that among non-Hispanic whites, what they found was that people living with HIV were less likely to test positive for COVID-19 compared to people living without HIV, and that's among the non-Hispanic white community. But among the non-Hispanic Black community, it was the other way around. People living with HIV were more likely to test positive for COVID-19, and at a greater rate, almost 3 times greater. And then among the Latino Hispanic community, there was a slight difference. There was a slight increased risk of people living with HIV to test positive for COVID-19. And among the Asian community, it more or less remained the same. So again, what this showed was that there were racial and ethnic disparities. And of course, the studies was does have some limitations limited to the U.S. National COVID Cohort Collaborative data sets. And like I mentioned, racial and ethnic data was not collected uniformly across the country, across different states. And there was no data collected on sexual orientation or gender identity. Just birth sex was the only data measure that was used. And of course, there was no data collected for social determinants of health, whether income, employment, health insurance. I mean, that was not collected either. So there were some parallels between HIV and COVID-19. And over the past year, and even what we've seen is that COVID-19 has impacted the Latinx community, in different ways. I mean, from having more jobs in the front lines, construction or food, or in care settings, you don't have the ability to social distance in many of these jobs. Accessing health services. When we're talking about poverty, we're talking about food insecurity, housing instability. I mean, the eviction moratoriums in a lot of states have helped, but at some point, some of this, regardless of the aid that a state or a federal government can provide, sometimes it just becomes unsustainable. So here, what we're seeing with this map, courtesy of AMFAR, the American Foundation for AIDS Research, and this was data that was collected, that was presented in February of this year, 2021, where we see in the map, the big map, we see where the highest rates of COVID-19 patients were diagnosed. So the darker the color, the greater number of confirmed COVID-19 patients. And just to juxtapose that with the ending the HIV epidemic jurisdictions, you kind of see you start to see a little bit of an overlap. I mean, Southern California, you can see a big overlap. You can see it in Miami-Dade County in Central Florida, that area, parts of Texas, parts of New York. And even though in the South, with many of these states that are part of the EHE plan, you do see a lot of dark blue, not light blue compared to some of the other areas around the country. Now here, where I am in Washington, you see dark blue in the area around Seattle, King County. But then the dark areas that you see are Yakima County, Benton Franklin County, which are, counties that have a large Latinx community, agricultural community that reside in those counties. Now, this was a chart that I saw. I think this was courtesy of the Latino Commission on AIDS in one of the presentations that they did around early summer. And what they found is that the proportion of what you see here, the blue lines that you see in the background, that shows you the percentage of Hispanics that tested positive for COVID-19, and then the gray area tells you the percentage of the Hispanic population in that state. So other than New Mexico, which is 49.1% made up of Latinx residents, and only 22% of Hispanics testing positive for COVID-19. Every other state in the country is the other way around. Less percentage of the total population in that state that they tested higher for COVID-19, at a greater rate for COVID-19. And then what was also seen was that in some states, in this case, they pulled out data for Oregon, Rhode Island, Utah, Virginia, here Washington State, was that Hispanics were more likely to end up in the hospitals in intensive care due to COVID-19 compared with other population groups. There were other population groups, especially Black African Americans, some American Indian and Alaskan Natives, that were also more likely to end up in intensive care. But in general, across all these states, Hispanics were greater, had greater possibility of ending up in intensive care because of COVID-19. And then, of course, when we talk about HIV and clearly when we're talking about COVID-19 in the past year, we've seen research about the effects that it has had on substance use and also mental health. So here, what you're seeing is the little circles are what was the prediction of drug overdose deaths, and you can start seeing it was slightly going up towards the end of 2019, but then starting January 2020, and especially as the pandemic really started to take hold here in the country, the prediction was that it was going to increase a little bit more. And the black line that you see is the actual reported value, where we did see that uptick. And you can go to this to the CDC website, access this data set, and you can pull down information by state. I think I had, let's see, there's something that came in chat. Oh, okay. All right, and then when we break it down by state, and here you see how each state did, especially in that time frame from July 2019 to July 2020. So remember back in March, well, end of February, March, when we started getting the first reports of COVID, of COVID happening around the country. Comparing 2019 to July 2020, there was a 22.8% increase of substance use during this 1 year period. And substance use usually does not, as you might know, substance use does not occur in a vacuum. Sometimes there's a trigger. Sometimes it's just the stress, the mental health stress of daily life. And obviously COVID has made that very, very difficult. You don't know if you have the ability to pay your rent anymore. You don't have enough food on your table, how you're going to feed yourself, how you're going to feed your family. You were laid off. Maybe your hours were reduced, your husband or wife's partner's hours were reduced, or they lost their job. You have a loss of income. And here what this chart is showing you is the self-reported stress that each population group had during that time frame of April to May 2020. And again, what we see that Hispanic Latino, which is the second to in each category, it's the second to last bar that you see, worried more about housing instability, worried more about not having enough food. They were second place in worrying about getting needed healthcare services, and also about losing their job or losing income. And this really weighs heavily on mental health, as I was mentioning. Latinos had reported having more depression, more suicidal thoughts or either ideation during the same time frame, April to May 2020, and also reported having an increased use of substances, or either increase or initiating use of substances. And we have also been seeing, in the past year, how this has also affected life expectancy. So here, what you're seeing in this graphic is the life expectancy at birth with COVID-19. Now that we're in the pandemic, it's in blue, and what it would have been absent COVID-19. So among the total population, there has been a decrease in maybe about 0.8 years of life. But among the Latinx community, it's almost 3 years of difference. And of course, among the Black African American community, it's 2 years, almost 2 years of difference. So we see here, at least what this chart is showing us, is that the life expectancy among the Latinx community has decreased has had a higher decrease compared to some of the other communities that they looked at this paper. And the same thing goes with life expectancy at age 65. Now, what are some of the underlying drivers of HIV and COVID? Because as we've been seeing, I mean, there is some overlap. So what are the underlying factors of the HIV and COVID epidemic among Latinx here in the United States? And some of this might you might be familiar with. I mean, from denial, from gender inequity, that machismo, that family concept, respeto, simpatía, personalismo, stigma. It's a big factor, not only in our community, but in most communities. Transphobia, that concept of dignidad is also present. That exploitation of culture and the drug or alcohol use. And drug and alcohol use, I mean, there's been papers in the past how that differs among each of our communities. If you're of Mexican or Mexican descent, you're more likely to use alcohol compared to if you are of Cuban or Cuban descent or Puerto Rican descent, where you might be more likely to use other substances. So, I mean, and that's the other thing. I mean, that's, everybody talks about, Latinos like as if we are a monocultural, monolithic community, and that we know it's just not true. I mean, there's huge differences among each of our backgrounds. And let's take some water. Some of the other factors that drive the HIV epidemic among the Latinx community are, of course, federal and local laws. I mean, there's been quite a few sessions in the conference this week that have looked at immigration laws. Of course, we just had a change in administration, and that's changed it. That's shifted some of those, the stance that the federal government has taken in some of these policies. But there's still some federal policies that curtail immigrant and sexual gender identity minority groups. And there are still HIV criminalization laws in many states. And these are not based on current science. And this just further stigmatizes people living with HIV. There's also this, inequality of opportunity. Latinos are less likely to access higher education, access healthcare, own a house, invest in their own businesses, own a business, vote, have access to legal representation. The lack of access to culturally appropriate services. I mean, the sad fact remains is that there are not enough Latinx medical and social services professionals in this country because of different reasons. I mean, there's economic reasons, the cost of just going to university, accessing postgraduate studies. I mean, who pays for that? But there's just not enough, and there's likely not going to be enough healthcare professionals, Latino, Latinx descent, to meet the needs of the population. So, I mean, we really need to work on increasing this cultural awareness and humility. I mean, this is critical. These two things are critical in reducing the health disparities and improving access to healthcare for the Latinx community. And of course, the fact of the matter remains is that the healthcare system here in the United States, it's so complicated to even understand. I mean, and that's, even maybe talking amongst ourselves who are probably better versed in the healthcare system or social services safety net system in the United States. Can you imagine how daunting this is to somebody who just immigrated to the United States, or somebody who simply, maybe they just found out that they have a chronic condition, and now all of a sudden, I mean, all of this it's so confusing. We're also, of course, with HIV, as with COVID, as we've been seeing in the last year, there's also stigma. There's also discrimination. 9 in 10 Latinx people living with HIV reported internalized HIV-related stigma. And what we've seen in the last year, this is also holds true for COVID-19. I mean, at the beginning, it was like, you test positive and you feel guilty because now you have to be quarantined. And then, the family that you live with are also at risk. So, and, how is that viewed from the outside? And of course, what we've been seeing with the Asian and Pacific Islander community is that stigma is real. It has serious consequences. And then when we're talking about HIV, we're also talking about, intersectional discrimination. We're talking about HIV does not exist in the vacuum. So you're dealing with somebody who might be HIV positive, but they might be, of a different race, in this case, Latinx. They might have a different sexual orientation, gender identity. What's their immigration status? So for a person who is living with HIV, it's not just about, okay, I'm going to go to the doctor and get get the care that I need. It's always that perception. It's my HIV status on top of the fact that I am Latinx, on top of the fact of my sexual orientation, on top of the fact that my gender identity, and on top of the fact that I might or might not be documented, or that somebody in my family might not be documented. So a lot of these things go into the mind of somebody when they decide or do not decide to access healthcare services, or if they feel discriminated against in their job, whether they seek legal representation or not. And of course, there's also migration-related risk factors: the cost of mobility, the cultural aspect, the linguistic, not only Spanish. I mean, and of course, most of us speak Spanish, but I mean, there's also a lot of other hundreds of different dialects that Latinos speak that come into the United States. The geographic barriers to healthcare, limited education, psychosocial factors, sexual practices, isolation, discrimination, poverty, unemployment, housing. These really all play a big role. And as I previously mentioned, the impact of COVID on HIV, the physical distancing, you can no longer get close to somebody. The changes in the workplace, whether a person can now work remote, where you are in a job that allows you to work remote, or whether you work in a job that is still force you to go in person, but probably did not give you the ability to protect yourself, because at the beginning there was just not enough tests going around. There was not enough PPE going around. How did that affect your sexual behaviors during the pandemic? As we talked about, the shift in drug use, that loss or reduction of employment, whether now all of a sudden you have to reduce your hours because somebody in your family was COVID positive, whether you had to quarantine or not because you were exposed to somebody who tested positive. And then early on in the pandemic, a lot of clinics were closed because really, if we look back to that March, April time period of 2020, I think everybody just did not know what to expect from this. And, a lot of health clinics did close. And now they're back up, but there's new protocols in place in many healthcare settings. So COVID-19 has affected HIV prevention, and sexual behavior, on harm reduction, changes in the service delivery models, telehealth, or home testing. I'm going to touch about telehealth further on in the presentation, and then the impact that that shelter-in-place measures had to access healthcare services, including HIV prevention and treatment, which I'm also going to touch on. Now, this is data from a health center in Boston, and what they saw was from that time period, March 2020, February, it's a time period, February 2020, because the first few cases were starting to get identified towards the end of February, especially that March, April. What they saw was that, PrEP lapses, people who were on PrEP and went off PrEP during that time frame increased exponentially, increased 3 times. New PrEP starts, which is the red line, decreased. And the cohort size at each month slightly went down, more or less it stayed stable, but it's that blue and red line. People stopped using PrEP 3 times the amount compared to January 2020, and the amount of new starts also decreased. So this is where telehealth really took an important role as we, as the pandemic really started to take hold. So CMS waived some key telehealth requirements. So now a lot of beneficiaries could receive services remotely, and providers could bill for telehealth services. And some states also modified those requirements for private insurance. And that was really, really helpful. On the HIV care and prevention side, HHS also published interim guidance that enable providers to prescribe 90 days of supplies for antiretroviral medications instead of 30 days. And mail order medications were now available instead of pickups. So, more clinics started sending those medications via the mail so that patients did not have to go directly into the clinic. And, whenever possible, extend the frequency or intervals between when people living with HIV had to have clinic or lab visits. And these are two studies, again, from Boston, that we saw how telehealth really took a major role in healthcare access. January, there was no telehealth visits, everything was in person, but by April, it had totally flipped around. And then likewise with people living with HIV, and that was for PrEP. And the other chart is for people living with HIV, the same thing. In person in January and February, everything was in person. By March, it was, those numbers in-person started to decrease exponentially, telehealth went up. And by April, it was just that explosion of that shift to telehealth services, because that was a new reality. Now, that's not to say that telehealth does not pose some challenges, because there are, whether it's from patient-focused or provider-focused. I think, I know I attended a session, I think it was on Monday in the conference, that looked at access to mobile devices as part of the agricultural worker study. And yes, the Hispanic, Latinos, Latinx, we do have access to the internet through our cell phones, but really, to access telehealth, do you need Wi-Fi? Do you need a higher bandwidth? How does that affect the ability to access services? Issues of privacy are also a big concern. Hopefully, the National Agricultural Worker Study can take a look at these things for next year. Then also the patient-provider interaction, is kind of impersonal. I know, during the summer, I myself did access some services via telehealth. It's kind of strange at the beginning. That's you're kind of used to having to go into the doctor into the clinic and seeing the nurse and seeing the doctor, and then you're doing it over the web, and it still feels a little bit strange. And then on the logistics side and the clinic operations side, at the beginning, it was a burden on many clinics as they had to put new protocols in place. And then for people living with HIV, what other type of wraparound services can be provided via telehealth? That doesn't mean that telehealth does not have its benefits. Some patients might prefer it. I know for the fact that not having to travel, get in my car, travel half hour, look for parking, or even, for a lot of people having to get on a bus, multiple buses, if they can do it over the web, and get some of those basic services covered over the web, that's a huge plus. You're also able to have more frequent visits. Telehealth enables you to do that. On the logistic and clinic operations, now there's more efficiency in the clinics. Clinics have been able to implement those policies. they can reach more patients. It's less, and there are studies out there saying that there are better show rates compared to in person. So these are some of the lessons learned, and I think I've got like 12 more minutes to go. So I'm gonna start going a little bit, skipping through a few of these bullets. But these are some of the lessons learned that have been learned by health clinics in the past year. Training staff to multitask. What happens if a staff member came tested positive for COVID? Now, that person cannot be in the clinic anymore. But what else can they do? Oops, sorry. Then, also train medical assistants to initiate telehealth visits, and also to help patients who are high risk for poor outcome for COVID-19 and HIV, and really provide them with that health education. That's something that you can do via telehealth, and that you may not necessarily need to do as an in-person visit. Now, on the HIV front, specifically talking in the HIV front, and this is for HIV prevention, new programs have been talking about PrEP. New ways of administering PrEP have been coming up in the last few years. One of them is pharmacy-based PrEP. These are some pharmacies around the country. Gateway is from St. Louis, I believe. Scales from Denver, Mission Wellness, San Francisco, Kelly Ross here in the Seattle area, and then the federal government with the Ready, Set, PrEP program that enables pharmacies to dispense PrEP, to do all the clinical work in order to get somebody signed up for PrEP and provide them with the medication instead of having to go to a doctor. So pharmacy-based PrEP is one of those approaches that can have a huge impact in HIV prevention going forward. And then in the future as well is the long-acting injectable cabotegravir, which this is an injection that a person just needs to take once every 2 months in order to prevent HIV infection. So instead of having to take a daily pill, having to have that bottle somewhere, maybe hidden in your kitchen or somewhere in your room, away from your family, so they won't see that you're taking this medication. Once every 2 months, you just have to go to your doctor or go to a clinician and get an injection. So that really empowers the person to keep their HIV status negative. So this is this is something that everybody's looking forward, that we are looking forward, looking towards the future. Now, overall, I think we really need to start looking at, we need to look at implicit bias. There's assumptions. I think we all have our inherent implicit bias. But really for providers is to, we need to take notice of what our assumptions are on a specific population group and really check if those are correct. And specifically when we're talking about Latinx, Latina patients, ask if their preferred language is in English or Spanish. There's other things other than healthcare that go into how a person approaches their healthcare, whether they have access to food, to transportation, poverty. Mental health is another thing that really, really has been neglected, not only in the past year, but, for a very, very long time. For HIV, specifically talking about HIV prevention, taking sexual histories in all patients. Your local AETC can help with training on that. Again, if you do not ask the questions, you don't know who might be at risk. So taking a sexual history serves that purpose. That's key in doing that. Of course, following CDC guidelines is testing all individuals between 13 and 64 years of age at least once in their lifetime. and identifying those who are at greater risk and testing them at least annually. And taking a sexual history really helps you do that. Being able to offer PrEP is another key strategy, especially sexually active individuals over 16 and those who inject drugs. And then emphasize the concept of U equals U, undetectable equals untransmittable. So if your HIV levels are so low in your blood, there's no way that you can transmit the virus to a person who's HIV negative. We talked about telehealth and the digital divide. Privacy is a big concern. Access to bandwidth, access to cell phones, or access to a computer or to a device that can enable you to have telehealth services, the use of the translator to be on the call. And then when we talk about culture, recognize those social determinants of health, capture their reality of racial and ethnic communities. And also acknowledge that there are traditional medical practices, and there's also fear of stigma, immigration status, when people access healthcare, and then the family-centered decision-making model, which I think it's we see more in the Latino community versus the individual or autonomy-based model. And then understanding race and ethnicity, focusing on recruiting and retaining staff who reflect the demographic, and the use of community health workers as a liaison. That's also key, not only in the Latino community, but in many communities. This is a proven and effective way to reach our communities. So with that, just like to thank everybody for taking the time and attending today. I don't know if there's any questions or comments. There was a lot of information. There was a lot of information to pack in 1 hour.
Victor, that was a very comprehensive overview, and we're so appreciative you could be here today to share your knowledge and expertise in this area. I want to let folks just be reminded that there is an evaluation for the session today. I did put that information in chat for you with the link, and would appreciate it if you would take a moment to complete this evaluation, because we really do appreciate your feedback. I'll repost for you the information for getting your CEUs if you're going to be asking for those, and then I'll turn it back to Victor for any last minute questions while I'm doing that.
Well, I would just say that, again, if you have any specific training needs, depending on where everybody comes from, where you're located, whether you are a clinical provider, whether you provide ancillary services, social services, a great resource is always your local AIDS education and training center. Anything that has to do with HIV, with comorbidities related to HIV, substance use, hepatitis, STDs, they are a great resource that you can access for free. And again, AETCs are funded by HRSA. This is where we get our funds from, and this is what we are purposed to do. So, if you have specific questions, how can I implement a sexual history taking across all my clinics? Your AETC will be able to help you with that. So, again, gracias a todos por estar aquí hoy, y espero que la información haya sido útil. Y gracias, thank you very much to the Northwest Regional Primary Care Association, who initially invited me to present in this conference. And keep up the great work. Adelante, sigamos con todo nuestro trabajo, y hay mucho que hacer para la comunidad latina y hay que seguir luchando. Sí, gracias.